Hello, my name is Ruben Mesa, and I'm the Executive Director of the Mesa Cancer Center at UT Health, San Antonio, MD Anderson. And we're going to focus on a topic today that I discussed in a session at the TCT meeting with my colleague, Dr. Gene Palmer from the Mayo Clinic in Arizona, regarding JAK inhibition and stem cell transplantation with patients with myelofibrosis. And really the question around what is the current state of the art in terms of these two approaches. Years ago, I would say that we focused on the therapy for myelofibrosis in two parallel tracks. Either a patient was going to stem cell transplantation or they went on to a JAK inhibitor. We realize now in 2021 that for almost all patients going on to stem cell transplantation, they have received or are receiving a JAK inhibitor. So what have we learned? First, JAK inhibition is helpful prior to stem cell transplantation overall, in particular in individuals that are having a good response in terms of improvement in splenomegaly, improvement in symptoms, likely improves their functional status. And we've not seen that there has necessarily been any increased toxicity for the transplant process with people being on a JAK inhibitor. Second, we've learned better regarding the interval between going from the JAK inhibitor to transplantation itself. We now continue that medication through into the time of conditioning. If individuals have been on a very high dose of JAK inhibitor, 15 or 20 milligrams twice a day, we may try to taper it down to a more modest dose. There are now multiple studies ongoing looking at continuing JAK inhibition throughout the time of transplantation. This remains experimental, but the thought being that one, it might be beneficial against graft versus host disease development, which is another indication for JAK inhibition at the current time. And perhaps it might have an impact on delaying relapse in individuals with higher risk disease features. These are still experimental endpoints, but still actively being ongoing and are being utilized. Now, the pipeline for therapies for myelofibrosis continue to evolve, and these are impacting this decision-making as well. So, for example, fedratinib has now been approved in the US and very recently in Europe. The individual that has been on a JAK inhibitor, let's say ruxolitinib, but has lost their benefit, and the plan is to go for a salvage transplant, may well benefit from switching to an alternative JAK inhibitor to try to regain some of that benefit of splenomegaly symptoms, improved performance status before moving on to transplant. Again, this remains an experimental question, but a very valid one to consider in the care of your patients, given that we have seen good second-line data for the use of fedratinib in these patients from the Jakarta 2 studies. There's multiple new therapies being developed, IMG 7289, CPI 0610, navitoclax, imetelstat, and many others that are having significant activity in the second line in myelofibrosis. And I undoubtedly envision that these additional targets and approaches may impact patients pre-transplant to improve outcomes. Likewise, if momelotinib or pacritinib become approved, they may become important options. Pacritinib helpful in that myelodepleted phenotype, momelotinib particularly with individuals with anemia. So more than ever, close teamwork between the hematologist who is actively prescribing myelofibrosis-related medications and specializes in that disease, as well as the stem cell transplanter, need to work closely together to integrate all aspects of care in the pre-transplant setting, setting those transplant goals, and in the peri-transplant setting. All these new therapies, I think, will continue to improve, hopefully, the outcomes that we see with stem cell transplantation in myelofibrosis.